All right, chemotherapeutics and side effects. You gotta be kidding me. All right, so this is just, you could reference this, but I've made tables for you. All right. All right, so cell cycle and classes overview. So again, this is the biggest one is our alkylating agents. There's the hugest variety that have been around since like the 50s. Okay, so cell cycle, certain drugs work on certain parts of the cell cycle. Technically, the alkylating agents don't happen just at one cycle. It happens like through the whole thing. But we'll go over the cell cycle, right? I'll see if I can draw it on the board at the same time so you can get a view of how it works. All right, so we end the previous phase with mitosis, right? We divide it into two cells, right? And now we're into G0. G0 is your resting phase. That's the phase where you are not doing anything. The cell is just there resting until it's time to make another cell. If it's a sperm cell or RBC, you got no time, right? No rest for the wicked. But otherwise, you're going to rest for X amount of time. If you're a skeletal muscle or you are a neuron or you are a heart muscle, you're in G0 for the rest of your life. You don't make any more cells. You have what you got, right? So you're always in G0, right? That's why you don't really get heart cancers or skeletal muscle cancers. You can, but you do get brain cancers, but it's usually the myelin sheath. It's not the neuroma itself, right? And then now we're in G1. G1 is your phase where you're making things, and you're making things for DNA replication, right? To make DNA, that means you're making all the little tools. I draw tools like triangles and squares and circles. You're making all the things for DNA replication, which is your S phase, your synthesis of DNA, right? So you want to make DNA into two DNAs, right? So there's another two DNAs. That's the whole point of replication. You're creating two DNAs so that you can then put one in one cell and one in the next cell when you go through mitosis, right? The next stage is your G2, and that's where you're preparing all the things for mitosis. I don't know what mitosis things look like, but you have a DNA molecule. You also have your mitosis stuff, like little spindles and chromosomes, all of the fun stuff, right? And then you finally go through mitosis, right? Which has its own little phases, right? So it has prophase, anaphase, telophase, right? All those fun guys. Okay, so that's what is on the top right corner there. Those are the different phases of normal cell function. So what we can do is we can interfere with the separation of the DNA. If it can't separate, it's like tying the shoes right there, right? You're tying the shoes, it can't separate, you can't make two DNA molecules, right? And that's what your alkylating agents do. They prevent the cell from separating, therefore the cell stops, right? It stops production. If it has the apoptosis kill switch, it will kill itself, but usually cancer cells don't, right? So it'll just stay there, and then we have to do radiation to kill it on its own, to destroy the cell membrane. We have building blocks of the DNA and RNA, right? These are made of little purines, right? Little base pairs here, and we have ways to inhibit those purines, right? Like we talked about, methotrexate is going to impair folic acid synthesis. Folic acid synthesis is for pyrimidine production, so you're going to stop that you don't have the building blocks for the DNA. You may be able to unravel it, right? But you don't have the building blocks. They're all gone because you gave methotrexate, for instance, right? There's other things such as that'll interfere with mitosis that we'll get to. But really with G1, we're building all the building blocks here, and we're unraveling our DNA. We're making copies, right? To make proteins, you need to make a copy of the DNA with RNA, right? So you're trying to make copies of things, and if your DNA can't open, you can't make copies. Therefore, we have little checkpoints, right? Little checkpoints right here. It's a G1 checkpoint, right? Let me make sure I got that right. So G1 little checkpoints. You say, how's everything going? It's like your boss coming up and say, how's everything going on your project right there? And like you haven't unraveled your DNA, you haven't opened anything. It's like, well, you know what? Apoptose. Okay, boss, guy, right? So then they would die at that point, right? And that's what can happen. We can stop it from making the proteins, and then it will stop making. It will stop altogether. Okay, so that is the idea behind the first few phases here, right? So the gap phase, gap 0, There's no chemotherapy that works on GAP0 because it's not dividing, right? There's no reason to divide. I mean, the chemotherapy is not going to work because chemotherapy works on rapidly dividing cells, right? So GAP0, nothing's really working there. We have permanent cells, like we mentioned, right? Stable tissues must be provided signals to go into G1. So there's little signals that get released here that will then trigger it to go into G1. And we're not going to get into all the different inhibitors out there. There's a lot of them. That's where a lot of cancer therapy is now, is we actually start inhibiting certain proteins, inhibiting certain chemicals, inhibiting certain processes, and that will then eliminate the cancer, hopefully, right? Those are called NIBs, by the way. So you got NIBs down here. So NIBs are inhibitors, all right? That's what they actually named it after, inhibitors, right? I think of cacao nibs, right? So you have little cyclins and kinases. Cyclins are like your foreman, which tell the cell what to do. If you inhibit the foreman, your cell gets lost and then it eventually dies, right? Kinases are your little workers, right? Kinases are your little workers, and if you inhibit the workers, you can't make cell stuff, right? So NIBs are kind of the first generation. So they usually have caused a lot of skin toxicity, a lot of bone marrow suppression, as we mentioned, right? But nowadays we have all kinds of other fancy medications. We have monoclonal antibodies. We have, what do they call it? It's other different variations that will inhibit certain parts of the cell cycle, okay? What else? So we have G1. So G1 and G2, the gap phases right here. These phases are where we're preparing for the next phase. Basically, we're getting all the stuff together before we go forward with replication in the synthesis phase, right? After we've made 2 copies, then we're going to make all the things we need for mitosis, right? And we have a checkpoint right before mitosis as well. So we have a little G2 checkpoint right here. It says, are you everything good? If it's not good, then the cell will be forced to die, right? It tells the cell, go ahead and go apoptose, right? Thank you for your time. It's time to go, okay? And of course, the cancer cells can say, you know what? I'm going to get rid of that protein. I'm going to turn that off, right? So they then just stay there, okay? So that's G1 checkpoint, G2 checkpoint, and our alkylating agents. So our alkylating agents, they are going to, again, there's a lot of them because over the last 50 years, they've made new ones here and there, but they usually have a C in the name for the most part, right? They also have lands and fans on it. There's some mustard gases from World War I in there. So you see musts. A popular one are plats, or platinum agents, right? So platinum agents down here all have plat in the name, which is nice. Cisplatin, oxaliplatin, carboplatin. They're an example of alkylating agent, whereas the other ones kind of have C's in the name for the most part. Cyclophosphamides are pretty popular. Cyclophosphamide and ifosfamide, they have the same function. And you can think of the CY as cystic, and cystic as in like cystitis, as in the bladder. It causes hemorrhagic cystitis, it causes your bladder to bleed, it causes your bladder to go into bladder cancer. So we have a medication that's green, right, that's going to prevent that. So Mesna is a medication you always give with cyclophosphamide and ifosfamide, right, which are alkylating agents. The mustards here, so we got chlorambucil. Again, I told you I wasn't really focused on chlorothamine, so we'll skip over that one. And then nitrosurases. So there's not many that are used here, but busulfan is a popular one. Busulfan is used for, is it bleomycin or busulfan? I can't remember now, for like testicular cancer. It's one of the Bs. Either way, the nice thing about the B chemotherapy agents is they all turn you blue, and they all make you blue because it causes pulmonary fibrosis. Makes your lungs not work good. Makes them fibrosed, and they can't vasodilate, and makes your skin blue. This one in particular can make you blind, make you have cataracts. So busulfan, and there's another one later called bleomycin. It blocks your breath and it turns you blue, is a way to remember that one. Okay, and then platinum agents. So platinum agents all have plat in the name, which is nice. They are the most significant for nausea and vomiting. All of these alkylating agents pretty much have nausea and vomiting, but these guys especially, number one, 90% of people who get this will vomit for 5 days after they get it, okay? So we're going to give some nausea medications, which we'll talk about later, but amifostine is a protective medication to avoid kidney damage. These guys are nephrotoxic, ototoxic. They're damaging to the eye, the nerve, not so much the eyes, and they cause significant nausea, vomiting. They're not great, but they are powerful agents for powerful cancers. Okay, these other agents, they're just there for fun. You might see them on some other slides, on like some other cancer therapies. Like, oh, that's where that one is. Okay, and we got our little antibiotics here. Again, we don't use these anymore for like infections. These are only used for chemotherapy. The nice thing about these antibiotics is they all have D in it somewhere. All right, so these are D antibiotics. So D antibiotics are actinomycin D, sometimes called dactinomycin. All right, it's kind of usually how it's on the street. But then we have anthracyclines. These all have D in the name. They got doxorubicin, daunorubicin, and those ones not used as much for idarubicin. They'll have D in the name, which is nice. And we mentioned these guys are toxic if they infiltrate, or they can cause significant extravasation, and also they cause a cardiac toxicity. So let me start a chemo man here. Let's erase this one. So when you do your different side effects to learn them, you want to try to draw this at least every day, right? So you have you can draw it as a chemo bear or a chemo man, right? So you have a head, we have the body here, we have the arms. We'll just do a bear, I guess. I guess we went to a bear real quick. Anyways, we have doxorubicin. So let's draw a red or purple. So doxorubicin, you could draw a D for the heart, all right? It is cardiotoxic, and we give dexrazoxane to prevent cardiac toxicity. You also give dexrazoxane for extravasation, if it were to extravasate. Cisplatin, CIS, right, or CP. Let's do it brown, I guess. All right. So cisplatin is toxic to where? To the kidneys. All right. So to a C backwards. All right. Those are your kidneys right there. And you got your ears right here, cisplatin. Right. So it's toxic to your ears and it's toxic to your kidneys. Right. What else is toxic to? We forgot to nausea, vomiting. So let's throw up some cisplatin. All right. So you got cisplatin as well. Okay. So it's very, very nausea, vomiting, or it's called emetogenic. All right, it generates emesis. All right, what else? We have antibiotics there. We talked about those. And then they cause bone marrow suppression. So we can put a little D down here also for bone marrow. We'll get to that. But we're at L-asparginase. So L-asparginase is kind of used for leukemias. That's why I throw it up there. It usually doesn't have that many side effects. But we're about NIBs. NIBs have skin toxicity. That's kind of the only thing to take home about NIBs. Okay, so that's the idea behind these phases. So G0, so you'd kind of draw these guys over here. That's purple, it's blue. All right, so as you're deciphering these, we have alkylating agents. Okay. All right, so going back to our alkylating agents, they're going to I didn't draw up here, when they make where's my purple at? When you make a protein, you have to make it off of DNA, right? Your DNA unravels here, it exposes its little base pairs, and then your RNA comes in, right? And you make a little copy of it, and you make little proteins. If you have alkylating agents which prevent that from opening, you're not going to make those proteins, right? So what else? So we've got alkylating agents there, and then we forgot to draw some IVs over here. So let's draw an IV for extravasation. So things that extravasate, right? So if you have doxorubicin, it's something that you have to give what for? What to fix that? You have to give dexrazoxane, right? If it infiltrates. If you have a platinum agent infiltrate, amifostine you're not going to give, but you give like cold packs, right? Vincristine is the only one you give what? Hot packs. Okay, and we'll get to vincristine, but everything else is cold packs, right? As far as things that infiltrate. All right, so synthesis phase and G2 phase. The synthesis phase is where you're making DNA copies, and the G2 phase is where you are making a all the things necessary for mitosis, right? All the proteins that are necessary for mitosis. So over here, we have synthesis phase. That's where you're making a copy. And to make a copy, you need to have all the little, what are they called? Purines and pyrimidines, right? Purines and pyrimidines. I spell pyrimidines wrong all the time. Anyways, you're going to inhibit those productions, or you're going to give things that are like little Trojan horses, like 5FU, and I didn't say anything bad to you, but 5FU and 6MP. These guys are anti-metabolites. They are going to block the production of DNA, and that's because they are mimicking these different base pairs, right? So we have purines, like folate. If you're inhibiting folate, such as a methotrexate, this medication is going to inhibit the production of these different little base pairs. And then we have like 6MP and 5FU. These guys are going to block they're mimicking base pairs, and therefore we can stop the production of DNA and RNA, right? What else? So DNA replication will occur in this phase, and then we'll be on to the G2 phase, right? And the G2 phase, basically, you are going to tighten, you're going to open up the DNA strand. You're going to open up like with these little, what are called topoisomerase enzymes. And we have chemotherapy drugs that inhibit those enzymes. So we can't open up our DNA. If you can't open up your DNA to make two strands to make copies of, you're going to be in trouble, right? That's where we're going to have these topoisomerase inhibitors, and that's going to stop cell production, right? Methotrexate, going back to that, we mentioned it in the first half that methotrexate needs leucovorin. Leucovorin is going to replace the folate, right? It's technically folinic acid. It's still B9, but it's folinic acid. It enters in later into the that whole cycle with the mother effers, right? So it's going to be in there, and it's going to, regular cancer cells can't use it, but our healthy cells can. So folinic acid is going to avoid the side effects of methotrexate. Methotrexate has all kinds of bad side effects. So what do we have for methotrexate? So first, it causes stomatitis. We'll put a little mustache on them, right? It's causing the mouth to be very, very sore. Methotrexate also damages the liver down there, right? What else does methotrexate do? I feel like I'm missing something. Pulmonary fibrosis, okay. But that's the big ones. It's going to cause drug-induced liver injury, and it's going to cause mucositis. And also down here in the bone marrow, we have to give what? To avoid bone marrow depression? We have to give B9. We have to give leucovorin. All right, so we'll draw that in green. I should have put dexrazoxane in green too. Okay, so those are the adding to our little chemo bear, chemo man. All right, so we have these topoisomerase inhibitors. We have different ones that will stop the unraveling of the DNA strands. All right, so we can't unravel it, then it's going to be marked for apoptosis. Okay, and these guys end in TCAN or topicide. So that's the nice thing about these ones. They have the same kind of name. The irinotecan has a significant diarrhea. So let's draw that. All right. So we have on the floor here, we have a whole bunch of irinotecan. We'll try to draw it into a petal. All right. So we got irinotecan as a complication is significant diarrhea. Okay. There's bleomycin. We have busulfan and bleomycin, 2B drugs, and these 2B drugs cause you to turn blue, pulmonary fibrosis, and blue skin. So we could draw blue skin maybe on the top over here. I don't know, but let's definitely draw some B's here. Let's try to get a different color going. Color haven't I used? All right. So let's draw big lungs here. All right. So B for bleomycin. You can put a little B over here for blue skin too. Okay. But B is for lungs. It causes you it blocks your breath, causes pulmonary fibrosis, and causes your you to become hypoxic. Okay. So bortezomib, that's used in some chemotherapies. It inhibits apoptosis. Okay. Sorry, it inhibits apoptosis inhibitors. So it's like almost a double negative. So usually the cancer cell produces apoptosis inhibitors that prevents it from dying. So this inhibits those apoptosis inhibitors. So it's a medication that's going to play the game. All right. So our topoisomerase inhibitors are the ones that open up the DNA. If you can't open it up, it's going to ravel super tight, right?
Helicopter, helicopter. Paracopter, paracopter. Helicopter, helicopter. Shalema kotrepa.
So you do the reverse with topoisomerase. It's going to unravel it. Okay. So also topoisomerase kind of like empties your whole pocketbook, and you're gonna put it back together. It kind of checks the whole thing, make sure everything's good before it's ready for mitosis. It doesn't want any errors to be in the next cell. All right, so mitosis. So remember this from fourth grade. We got our I party more at the club. Not in fourth grade. I prefer milk and tea is another acronym. All right, so prefer milk and tea. All right, so PMAT. And the interphase was actually everything we did up to this point. That's the other stuff we were doing, right? And then the PMAT are the other different phases. And basically we have chemotherapy drugs that work on the metaphase, right? And telophase, I believe. Yeah, metaphase and telophase. And these guys are going to inhibit these little cytochromes. These microtubules, and they're also going to stop the microtubules from being functional, and therefore if they're not functional and they're sticky, it's going to stop the cell from dividing, right? And that's going to cause it to not undergo mitosis and hopefully halt the production of stop the production of that tumor cell. Okay, there's also an M checkpoint in here that it establishes whether it's a functional cell or not, and then it might make it go through apoptosis again. Okay, so here's where we have vincristine, right? And vincristine we give what? We got the crispy hot packs here. Vincristine also causes significant peripheral neuropathy, all right? So it crisps your nerves as well. So you have to use crispy hot packs, and it crisps your nerves as a side effect of vincristine. Okay, also taxanes, they also cause a swollen hands and feet. Oops, taxanes. So taxanes were going to cause swollen hands and feet and peripheral neuropathy. And we forgot to put 5-FU up here. 5-FU is going to cause a purple, all right? 5-FU is going to cause significant diarrhea as well. So you can draw it like a GI tract, and it's going to make its way down here as well. And what we also forgot was cyclophosphamide. So cyclophosphamide, let's do or ifosfamide also. Let's do an I with an F, right, for a hemorrhagic cystitis, right? We have hemorrhagic cystitis for ifosfamide and cyclophosphamide. And what's the medication we give to prevent that? That's going to be Mesna. Okay, so I think that's all of them. All right, so here's examples of chemotherapy. All right, a lot of these we talked about with like GI cancers, right? They combine these different agents, and oftentimes they use the brand name, which doesn't help. So these are the different regimens, but like ABVD and FOLFIRI and RCHOP, they've been around for like 30 years. They have not changed, right? Sometimes we have newer agents and newer strategies we can use, but this is really based on research, right? And this overview shows all the different things. This is what I was trying to draw on the board right here, right? We have different agents that are coming in at different spots to inhibit the cell cycle, right? And the cell needs to be able to separate, and sometimes it cannot separate because we have alkylating agents. And sometimes we have this little enzyme that separates it as well, the topoisomerase enzyme, and we have topoisomerase inhibitors, right? And sometimes we have metabolites that get blocked, like methotrexate blocks the production of those little, the base pairs. And then we have like 5-FU and 6-MP as athioprine that block that as well. All right, so general side effects of chemotherapy. So head to toe, so we have our chemo bear. We can draw head to toe also are just general side effects. So you think of alopecia up top, okay? You got mouth sores right here. Who causes mouth sores a lot? It's methotrexate, right? And what else? We got chemo brain is a common side effect. Chemo fog, chemo brain. So we want to know what the side effects are, but also what are some teaching strategies you can do. That's kind of what the table illustrates there. Nausea, vomiting. So you got nausea, vomiting here, and we have certain medications we can give for nausea, vomiting. And ironically, you think well, not ironic, but surprisingly, that steroids are antiemetic. They're very, very strong antiemetics. So you can give those. Usually give them for 4 to 5 days of our cisplatin therapy here. They'll give it for like 5 days. Okay, and a aprepitant is the number one antiemetic that's really well tolerated. So aprepitant and dexamethasone, those are usually strong antiemetics we give for patients that have chemotherapy-related nausea, vomiting, which is CINV. Okay, so nausea, vomiting, skin changes. They'll get rashes. They'll get the peripheral neuropathy and such. So peripheral neuropathy, obviously, they're a fall risk, but also with rashes, we have to, they have to be, they can be photosensitive. So we're going to be giving recommending sunscreen, hats, sunglasses, all that fun stuff. What else? Infertility. So they can bank their eggs or sperm. Banks. I don't know what that means. So infertility. Okay. Infertility. And then what else? We have diarrhea. So diarrhea has there's significant ones that cause diarrhea, such as irinotecan there. And usually it's just loperamide. That's usually our go-to agent. Usually we sent home with a PO version so they can just use it at home. Okay. So these are different strategies we would do for someone that has nausea, vomiting. All right, make sure they're washing their mouth out frequently. Make sure they are they're not eating greasy foods, right? Keep their mouth clean. What else? They're hydrating because they're high risk for dehydration. What other symptom would they be high risk for dehydration for? Be the next one down, diarrhea, right? Diarrhea is also high risk. They got to avoid caffeine, ETOH, that'll put them at risk for diarrhea as well. Avoiding greasy, fatty foods. And then what else? So mucositis, you got to keep their mouth clean. Don't use alcohol mouthwashes. That will make their mouth even drier. And what else? They might have taste changes as well. So they can use sweet and sour and salty flavors, but not spicy. Spicy can irritate those mouth ulcers. Okay, they can rinse the mouth out with baking soda as an option. And infertility, we mentioned they can bank their eggs or sperm. Alopecia, there's no real medications we can give, but we can let them know that it will grow back. After chemo is done, it'll grow back different, but it will grow back. And what else on that? It can be sensitive scalp, so they can make sure they're wearing hats and such. And then we mentioned skin changes, but mental changes, chemo fog, they got to plan their day. They got to make sure they're safe as far as what they're going to do. Psychotherapy for pain, physiotherapy for pain, psychological support for the chemotherapy itself. And then skin changes, we mentioned sunscreen and such. And then bone marrow suppression, just like with neutropenic fever with our leukemias. We're going to do the same thing here. They're going to make sure they're not using, they're at high alert for sepsis. When we teach them how do we teach someone who that might be at risk for sepsis? Teach them time, right? They're bleeding risk with myelosuppression. So they're anemic, they're thrombocytopenic, and there's leukopenic, right? So if they're thrombocytopenic, they're high risk for bleeding. So we teach Randy and all the bleeding precautions. And then what else? Notify any kind of fever that absolutely needs to be addressed to make sure they are not getting a subsequent infection while they're on chemotherapy. And then opportunistic infections, there's a thrush in their mouth. They get mucormycosis, is an invasive fungus that eats into the brain, which is not good. It's fatal if that happens. And then we talked about specific toxicities we can avoid with dexamethasone, leucovorin, Mesna. Those are medications we can give to avoid the side effects of specific chemotherapies.
I've played all my cards, and that's what you've done to me.
We only have 2 more, right?
Nothing
11.
to say. No more race to play. The winner takes it all. The loser stands once more beside the victory. That's a destiny.
All right, so chemotherapy has a huge impact on your life. All right, so our last step is our different medications. This is a summary slide, what we've been drawing on the whiteboard, what we've been learning as far as all our different antibiotics, right? So you want to do head to toe, try to get this going, just kind of talk it through. Chemobrain, what I do, alopecia, what I do, what do I do for rashes, what I do for infertility, just kind of go down the board. I don't think this is complete, and I think this is complete right here. This has all of our different side effects, right? And these are side effects that haven't changed in the last 40, 50 years. These are very, very common side effects, and these are things that get tested on. Okay, and then our cell cycle, this can help you. It may or may not help you. Kind of shows where they work and what they do, right? So the alkylating agents prevent the DNA. The antimetabolites stop the purine and pyrimidines from being introduced into the DNA, RNA. So these are all different ways to digest this material. Instead of saying, here's a list of chemotherapy you have to know and you're getting tested on, here is, hopefully a strategy to understand it. Okay, so that's the idea. So this is another example of the chemo bear. We're not doing tamoxifen, but
let's memorize the chemotherapy toxicities in 60 seconds. Guys, you have to see this. So this is our chemotoxicity bear, and we're going to fill it in. Starting with the limbs, place 4 V's because vincristine is associated with peripheral neuropathy. Then place 2 C's for the ears and 2 C's for the kidneys because cisplatin is associated with ototoxicity and nephrotoxicity. Then you're going to place 2 T's for the eyes because tamoxifen is associated with ocular toxicities. Then you're going to place a D over the heart because doxorubicin is associated with cardiotoxicity. Then 2 B's for the lungs because bleomycin is associated with pulmonary fibrosis. Then you're going to place a CY over the bladder because cyclophosphamide is associated with hemorrhagic cystitis. Finally, place 5,6-M on the limbs because M-methotrexate, 5-fluorouracil, and 6-MP are all associated with myelosuppression.
All right, I didn't do the 5,6-FU, but those guys are also associated down here. Okay, as myelosuppressant, they're going to suppress your bone marrow and have the highest risk of that. Okay, all right, so that's chemotherapy.